Hey, hi everybody. Welcome to the N3C Community Forum for this for our May session. Glad to see everyone again. Sorry about my voice. Still recovering from a cold. Trustee, if you could put the next slide. As you all know, the presentation will be recorded and archived on our YouTube channel, so you could check it out after the fact if you couldn't make the meeting live. And for today, if you have any questions, please post in the Q&A. And I believe Sharon is also monitoring, but there's a point where you want to ask a question, just raise your hand and Tristan will help to unmute you. Okay, next slide. Just an update from the N3C Data Enclave. We are currently now at 22.6 million people in our, we have data on 22.6 million people with 8.8 million COVID patients and billions of rows of data. Next slide, please. And just for the upcoming presentations, so that you know what's on the schedule, in June, we're going to be talking about algorithmic best practices. And in July, real world data with HL7 samples and project implementation. Next slide. And it's with great pleasure that we introduce Dr. Lesley Cottrell and her team. They're going to be speaking about a topic which, personally, as a clinician, I'm very excited about in terms of looking at disability populations and how COVID has affected them. It's so difficult to get data on disabilities, especially from the EHR, and I'm really excited to see what her and her group have done doing in this work. So I'll turn it over to you guys to maybe introduce the team and take us through. Thank you.
Hello, so thank you for having us here this evening. I am Sharon Patrick from the West Virginia Clinical and Translational Science Institute, and I am also the IDEA CTR manager, and so I am also a part of the Lifespan Disabilities domain team led by Dr. Lesley Cottrell, and we have James Cheng on the call this evening also, who is going to walk us through some of our findings that we have discovered from this project. So we'll go ahead, and I want to just confirm you are seeing my slides. Okay, so as you saw in the flyer, we have the initial look at COVID-19 among disability populations.
Sharon, we cannot see the slides.
Oh, I'm sorry. I didn't see my green. How about now?
Yeah.
Okay,
Yep,
sorry.
we can see them. Great.
Okay, so a little bit about the Lifespan Disabilities domain team. Our mission is the mission of the team is to advance practices and policies that improve the education, access, and health of all people with developmental and other disabilities, as well as their families, by examining extent to which individuals with disabilities have been affected by COVID-19 diagnosis and access to appropriate treatments and follow-up. Our team started meeting clear back in June of 2021, and we started to look at codes to define disability. And we are still continuing to meet. We meet every 2 weeks by way of Zoom. And our next meeting is May the 24th at 1 p.m. Eastern. And we have some information at the end of the discussion this evening with how to join our team. So a little bit of our presentation overview is, of course, a little bit about the Lifespan Disabilities domain team. We have are going to look at the and examine representation of individuals with disabilities in the N3C sample. We're going to explore potential differences in COVID-19 symptom severity across disability subgroups and non-disability control. We're also going to compare select treatment patterns during the active COVID-19 period across sample and varying ability, and also some future projects and ideas. So some of the authors and our parts of our domain team, as we mentioned, are lead Dr. Cottrell, Mr. Chen. We had also Amy Burt from West Virginia University, Jeffrey Amons from the West Virginia Clinical and Translational Science Institute, as well as Amber Abel from the CTSI, the West Virginia CTSI, and also Dr. Will Beasley from Oklahoma. So that is a little bit of our team. And I'll go ahead and stop sharing so I can pass it on over.
All right. Thanks, Sharon. Okay. So as Sharon mentioned, can you see my slides? I'll double check. Okay.
Yes.
Sharon mentioned, she introduced our team. I will say that the focus of our domain is lifespan, and it has a wide variety in terms of disabilities. The first approach in that last slide for our first manuscript was really focused, and we'll go into that a little bit more specific, but the intent is acute, chronic, intellectual, developmental disabilities really are within our umbrella and of interest. So our team also represents disciplines that look at disabilities from a very wide view as a result. So we have pediatricians, we have gerontologists, we have OTPT, speech path. I'm a developmental psychologist. So we love that variety, and it adds to the variety of what the questions that we pose. So initially, to that effect, let's define that a little bit more closely. So why are we looking at individuals with disabilities? Typically, they are underrepresented in research, and for a couple of different reasons. Either they are put into larger categories without the designation of a disability to really tease that out. Are there differences? Or they're left out because of the disability. And that's really something that we wanted to pay attention to, because when we talk about COVID, many times this is a population that is more vulnerable to the social, the economic, to the emotional, as well as the physical impact of whatever you're talking about. And in this case, COVID, of course, could potentially, or this is one of the questions, there could be some disparities based on disabilities. They tend to be particularly certain types of disabilities. At least anecdotally, there were questions about the difficulty to tease out the treatments that were needed and rations of treatments for someone who has a chronic disability, right? Or who might already have a particular outcome. So for those reasons, we really wanted to shed light on this group. And then secondly, on this slide, what you see is for emergency planning. COVID really hit all of us in a way that we didn't expect. And any emergency hits individuals with disabilities of any type harder than others. So access can be limited in the beginning. Access burdens can be enhanced during an emergency, such as COVID. In this case, you have a couple of examples. So COVID in particular, we know that ventilators, for instance, there were only a select number. So how were they rationed? How were they assigned? And was there any difference in terms of use among individuals with disabilities or access to that? Usually individuals with disabilities have an essential personnel, an aide of some type, or the guardian is key. And those were limited in terms of how they could come in with them. And then the materials and processes and plain language and access screen reading, all of that continues and is just enhanced during that time. So then that leaves out some important information to people who need it. So I mentioned rationing. Decisions were difficult for medical personnel when resources were limited. And so that was a main piece in the back of our minds for whether individuals with disabilities could have been positive or negatively influenced by that. When we go to look at COVID at the time, now this has since improved substantially since 2021, but at the time, you didn't see a lot in terms of anything, outcomes, prevalence, severity, anything teased out for disabilities of any sort. Again, now you can see a little bit of it, but it's still not to the extent that we have for other populations. So we needed to look at data. We needed to look, and N3C was perfect for taking a look at that. And of course, what we could use for that is, as decisions were made, again, using it in a preventive way for next steps, next emergency situations. And this also goes outside of the inpatient setting. It goes for the outpatient, which we'll talk about later when James mentions AIM-3 in particular. But it also, even now, with some of the processes and policies that we're talking about. So for the initial study, let's go ahead and define disability even further. So participants were included in this first attempt we really wanted to narrow it down. So we had traumatic brain injury, and we have particular ICD-10 codes that we used for that. The second group was those with intellectual and or developmental disabilities. So we had about 5 or 6 ICD-10 codes for that. And then a combination, recognizing that many times we see someone with an intellectual and or developmental disability who has had one or more TBIs. So did they look any differently? Do we have some additive effects here? And then the fourth group was an age-matched control without a disability. So we have 3 total aims. The first aim, again, we were starting from scratch at the time. So COVID-19 prevalence. How did the prevalence look? The reported prevalence of COVID look across those 4 categories. So control, non-disability control, TBI, intellectual developmental disability, or I'll say IDD for short, and then a combined group. And take a look at age, gender, body mass index, things that might increase the risk for severity in COVID symptoms at the time. So that's aim 1, we'll talk about. Aim 2 is looking at COVID severity across those same disability categories as well as the control. And then aim 3 was starting to dabble into the ideas of what treatments were available to them. And our team composition will come into play here, as well as some of the challenges. And I'm going to leave that to James. So just some examples of the measures that were incorporated into these. Again, remember, it's lifespan. So we have children, adolescents, adults of all ages in this. So obviously the partner ID, demographics, age, gender, welfare services were incorporated in this because we recognize that when you have an additional state guardian having to access, perhaps that would even, we wanted to control for that in some aspects. Health indices, institutionalized individuals, again, potential additional challenges with access. I've mentioned the body mass index, and then I've mentioned the disability category. Smoking, the Carlson Severity Index, of course, was used for aim 2, and then combined therapies. So we had OT, PT, and then some ICD or treatment codes that we really struggled with taking a look at. I mentioned ventilators earlier. We struggled with the documentation of that. And so we're going to pull in your brains for chat, Q&A, get your ideas for how to really narrow that down moving forward. But you can see here, timing was also. So 6 months prior to COVID diagnosis, 6 months post. I'm not going to let the cat out of the bag for that. That's James, but that became an interesting piece. And then taking a look at the occupational and physical therapy services inpatient. So who did we have involved in this? This is reading from left to right. We incorporated the 3 cohorts of individuals. 2020, and I want you to take a look at, pay particular attention to the representation of individuals with disabilities over time. So of course our controls hung around about 80%. For intellect or IDD, we were highest in the 2022 cohort with 4.1% of the sample having a reported IDD or intellectual and developmental disability, lowest being in that first cohort. Traumatic brain injury kind of hung around the 9% to 10.4, again, highest in the 2022. And then a combined with 1%, a little over 1% or lower. The we did first half, second half, so you can see slight changes as well in the second half with higher numbers, particularly in traumatic brain injury in the second half of the 2022 cohort, with up to 16% of the sample having a traumatic brain injury and 5.2% having an IDD, and then 1.8% combined. So we're still talking about a small portion of the sample, but again, with potentially significant costs associated with it in a vulnerable population that can have lasting effects. I mentioned for aim 1, we took a look at age, gender, some of the characteristics, and so those are presented here. I know this is a busy slide. Total numbers are included at the top. Even a 1% of the sample equates to, 100,000 plus individuals. Severity was a factor. Again, paying particular attention to the last 3 columns, or the 3 columns on the right. You have pretty severe, which we're going to see here in more visual slides later, but pretty severe COVID among TBI. So about 1/3 of the population with severe, 1/4 of those ending with death in some instances among TBI in particular, followed by IDD individuals with 3% having severe being the most represented. But still a lot of unknowns. So the documentation is still something that we should keep in our minds for individuals with disabilities. Our age was across the span. Again, we have more reported for traumatic brain injury cases, but we do have across the lifespan here, which will come into play for interpretation. And same thing with body mass index across the board, so we could take a look at it. Gender, again, pretty equal representation in the disability groups and the combined. Significant smoking among the traumatic brain injury, the patients with traumatic brain injury, and then the welfare services. Again, that was just kind of a control factor that we recognize, particularly for the pediatric cases in the sample. And we do have some that we could take a look at that for future studies if we were interested. Okay, and then let me pause there. Any questions about M1? I don't have that open. Okay, we can come back to that. So AIM-2 was looking at severity. So we're going to get look more closely into the Carlson index for that. And again, mentioned in the past few slides that particularly in the traumatic brain, patients with traumatic brain injury, we had more severe levels and even death. So we took a closer look, 4 different types of models for that particular outcome. And you can see that here: death, or severe or moderate or inpatient ED admission, or you can look at death or severe or moderate, death or severe, and then death. And then predictors of severity, COVID severity, again, that disability category, the 4 groups that we had, the Carlson, and then some of the demographics that we wanted to control for that I mentioned earlier. We looked at 1 time point per patient, which was a point of discussion among the group. We can look at that a little differently along the way, but for this one, we chose 1 time point, and then a logistic GE regression was done for this particular aim. All right. Okay, so to take a look at it again for the COVID severity, the darker orange is going to be the more severe. The gray on the bottom is going to be the less severe. The categories on the bottom, so control to the left, and then the IDD group, or intellectual and developmental disabilities, is that second line from the left. Patients with traumatic brain injuries is the 3rd line, and then our combined group is the last on the right. So you can see the highest, or I should say, the group that had the most, the highest proportion of severe, Carlson, if we followed it from the top to the bottom, was that group of patients with traumatic brain injury, followed by that combined group, and then IDD was the lowest. And that kind of pattern followed through most of the severity groups. So again, the TBI group having the highest prevalence of whatever level, the 5 to 7, the 3 to 4 was similar, except when those 2 middles, the combined, did have a higher prevalence of those moderate. But IDD tended to be one of the lowest. Okay, and some of the things that we can talk about the interpretation, but one of the things we might recall is during COVID, during those times, that IDD might have other medical conditions that they need to be aware of. So at that time, they might have isolated themselves, not really reported unless it was pretty severe, while in patients with traumatic brain injuries might have been more often out and about or seeking services from their providers during COVID. But we can talk about that later. If we take a look at it with moderate or worse, again, there was 4 different ways to look at it. If we look at it from the moderate or worse, we see similar patterns, okay, with the 1 to 2 or 3 to 4 range is kind of looking like this linear increase from the match to the combined group having the highest prevalence of that. But again, you notice the most severe had the highest with the patients with TBI, then the control or the combined, excuse me, and the individuals with IDD were the lowest. So again, very similar in pattern. If we look at outcome being severity, the most severe or death, I want to pay attention to the boundaries here, the outliers, the kind of confidence intervals, which are the light orange. So we do get bigger and bigger and overlapping, which should be factored into our interpretation here. But we do also start to see different patterns with that we need to be discussing. So the combined group, for instance, in the most severe was low, comparable to those with IDD. Traumatic brain injury stayed highest, okay? And some of those linear piece patterns that we saw in the previous definitions or approaches start to level out a little bit more. And then lastly, if we just look at death as an outcome, again, they overlap with one another. We should be conservative in our interpretation of this, but then the combined group continues to be the lowest in terms of prevalence of death from COVID, with TBI and even IDD and the match start to level out. Okay, so if we look at them all together, a couple of things that I want to pull out of that and kind of stay out of the pattern so much, but individuals with traumatic brain injuries would be a group that we would want to take a look at and continue to look at more closely, in my opinion. Regardless of what outcome you use, they tend to remain up there as a group that needs to be looked at. The IDD group is low, except with death as an outcome. But again, that's overlaying, so we need to be careful with that. But it could also be a question we need to think about the patterns of healthcare seeking at the time, and of course, other factors going on. Let me stop there. I see some Q&A coming in. And we can take a look at that. So in regards to aim 1, were any social determinants of health variables available for consideration or only welfare? So Cameron, there's potentially others that we were taking a look at. We were not exhaustive with that case. I think there are some that we could continue to look at, and we're going to get at with some future studies. But we weren't exhaustive. We were just starting to touch the surface with the welfare piece. Did the severity percentage change with time during the pandemic? That's really good. We're going to get at that a little bit with AIM 3, but that's something we need to come back to, Warren. I think we did not look at, well, I don't remember. James, do you remember if we looked at, I'm not to put you on the spot, but did we look at severity by cohort? I know there was a lot of analyses, and I need to go back to it. We can come back to you, Warren. But do you remember, James?
Yes, we did look at severity percentage change by cohort. Am I coming through? Am I still on mute?
No, we hear you. Okay. And again, that kind of goes back to the greater representation of both or all 3 groups, the combined, the TBI and the IDD, and that last, the 3rd cohort for sure, compared to the other 2. But we can come back to Warren. I can look that up. And then, and the Carlson index was specific to the acute SARS-CoV-2 infection. Yes. Thank you. Okay, let me turn it over to you, James. I'll stop sharing.
Thank you, Lesley. Can I just check, are we all seeing my slide, aim2 methods, and my mouse moving around?
Yes.
Yes.
Okay, great. Well, thank you, Dr. Cottrell, for both framing today's presentation and as well as leading this project over the past year, or maybe it's been almost 2 years. Well, anyway, I'm here to talk about the methods and results for our analyses. For a little bit more about aim2, slightly different perspective from what Lesley shared, and also for aim3, of course. But before I do so, I feel compelled to start with an apology and also a request. The apology reads a little bit like a program note you might see at a musical theater performance. We regret to inform you that due to unforeseen circumstances, the originally scheduled statistician, Dr. William Beasley, will be unable to present today, and you're instead left with the understudy. That'd be me. And I'm not really a statistician. Will gets all the credit for the heavy lifting and building the models. And well, I guess I get to claim all of the mistakes in today's presentation. Thank you for understanding, and I hope you will still enjoy the show. Now, I'm trying to be funny, of course, and I can only assume that all of you are laughing into your muted microphones. But let me stress that Will wished he could be here, not only to present, but also to participate in the discussion and to hear your ideas. Now, and I'll do my best to relay everything to him later. And so that brings me to the request, which Lesley already mentioned. We would love to get your input. Please write in the chat. If it's hard to explain your idea in the chat, maybe you could reach out to us afterwards. We could definitely benefit from the wealth of experience in this virtual room. Okay, now I'm moving back a little bit, and I don't need to go through this slide again, except that I did want to point one thing that I think can be confusing. For each of these 4 related COVID models, the outcome is the only thing that's different. And it looks like, well, I just want to point out that it's a binary outcome. A patient is either yes or no. Yes to death, severe, moderate, or hospital admission, or no, none of that. So for this first model, you're either in the category or you're not. It's not, we're not really dividing it into 4 or 5 different categories of control. And it gets more restrictive as we move along. And we're just wanting to see whether the pattern holds as we move through the progressively smaller subsets. Okay, so next slide. Lesley already went over this, and I think the only thing that I wanted to add to it is that you'll see that the slopes in these lines aren't all exactly the same, which just demonstrates that there's some interaction between disability category, control, intellectual, TBI combined for the x-axis, and some interaction between that and the Carlson comorbidity index, which you can see this is 0 if you have a CCI score of 1 or 2, 3 or 4, 5 or 7, or 8 plus, respectively. So I just wanted to point out the interaction. We were pleased to see that there was some interaction there. In the next slide, I do think this bears mentioning, but there's one element I want to point out. On the one hand, for each of these CCI scores, they're all sloping up. That's true, but I did want to point out that, for example, for this CCI score of 0, we're moving from about a 15% here. I don't know if you can read these numbers, they're kind of small, but about 15% to almost 30%. So that's representing a doubling in the risk. And if you were to say, take this CCI score of 5 to 7 right here, it's still going up, true. The control is a little over 60, and those with the highest chance, the combined, you might have over 70% chance. According to the model, we have a 70% chance of an outcome of moderate COVID or severe COVID or death. Now 60 to 70, that's not a doubling. And we feel like what this model suggests is that the effect is more pronounced in the populations with the lower CCI scores. And perhaps that's due to getting close to the ceiling here. I mean, this says 80% right here. So so maybe it's just a matter of getting close to the ceiling. Anyway, our model seems to suggest that the effect is more pronounced for those with lower CCI scores. Lesley already pointed out the wider error bars, or the confidence intervals, and yeah, I don't think there's much more to add there. And I think the only thing I want to say right here is, yes, these error bars are huge. But if you look down here, it's a little bit hard to see. The gray line looks pretty flat, but let's just say this is 0.2% to 0.4%. It's not that exactly, but that's still a doubling of the risk that our model shows. And so in summary, as we look at all four of these, this is the least restrictive. This is hospital admission or worse, moderate COVID, severe COVID or death, just severe COVID or death, and lastly death. We see some things. In general, we were happy with the consistency of these outcomes. We see the nice gradients, especially for the less restrictive models, and it shows that it confirms that disabilities are correlated to worse outcomes. And that's all I really wanted to add to what Lesley said. Let's see. I'll take a pause there and see if there's anything in the Q&A. I think we already answered this, so maybe there's not much to add there. Sharon, do you see anything else on your end?
No, I do not, but we are very happy to hear the community's input.
Yes, absolutely. So I'm not sure if I'm able to see if anyone has raised their hand or not. Well, without further ado, let me just say that we, on the analyst side, our team felt like Dr. Cottrell's concept was really well thought out. But those of us on the analysis side, we had some difficulty in getting to translate to work with this data set. And some of the questions that we struggled with as a whole, all of us were struggling with this. They included, where did the patients get their care? Was it through one of these hospital systems that feed N3C or not? And as a result, we don't know if their level of care actually dropped or not. And if their level of care did drop, would we be able to tell? And so all that to say, I just want to mention again, if any of you have ideas, we would love to hear them. And I think that's particularly relevant for AIM-3. AIM-3, as you might remember, our third aim was to compare and evaluate treatments obtained before and after COVID by disability category. And we decided on OT and PT, just like Lesley was saying earlier. And this wasn't perfect, but based on our model, we again used a generalized estimating equation model, which is similar to a multi-level model. We were counting visits, and this time we were interested in two time points per patient, before COVID and after COVID. Okay, and yes, again, there are 4 related models. I'll mention those as we go through in these next slides. These visualizations, they really could stand to benefit from some explanation. So let me slow down a little bit and point out a few things, especially since this text is so small. I don't know if you can read it. The thing that jumps out first are the colors, of course. The colors correspond with disability types. So that's green for combined, blue for TBI, traumatic brain injury, orange for intellectual disabilities, and gray for control. And they sometimes overlap. So that just looks like a dark orange, but it puts both of them right there. Each of these next few slides has 5 panels on it, 5 panels, and they correspond with CCI scores of 0, 1 to 2, 3 to 4, 5 to 7, and then down here, 8 plus. Okay, and the y-axis, this is the count of therapy visits, and let me stress, this is the average count of visits per patient across the whole cohort. So for example, this one might be the most visible. So let's say we're looking at the population that has a CCI score of 8 or more, and we're showing and exhibiting combined, they're part of the combined disability group. So we're seeing that on average, patients pre-COVID diagnosis would have a little bit more than 0.6 visits per person. And then after COVID, post-COVID, it went down to below 0.6 visits on average per person. And so that is what these are showing right here. Well, yeah, I mean, this is showing that pre and post-COVID, their visits went down, unfortunately. Now, one thing we didn't really expect was that for all the other panels, the slopes went up. You know, so for all of these, it seemed to show in the hospital systems anyway that we saw more visits, slightly more therapy visits per person on average after their COVID diagnosis. And you guys might have some ideas of why that might be the case. We've thrown out a few theories, but in any case, that combined with the fact that these counts are so low, I mean, you'll see this is 0.2, 0.4, and 0.6 visits on average per person, per patient, per person. We felt like they were really low, and we didn't feel like we could trust this model very much. So as a result, we added a restriction. We thought, well, maybe let's just look at those patients where we had at least one visit per patient in the hospital systems. So let me move to the next slide. It looks very similar. Here we're restricting to plus 1 or more visits, and you see that the numbers do increase. So the counts are, this is 0.5, 1, and 1.5. That's what those lines are showing on average per patient. Unfortunately, this did not move the needle much in terms of interaction. Within each panel, CCI 0, CCI 1 and 2, etc., the lines are very similar. You know, you see same place, same slope, and again, they seem to be sloping upwards, except for CCI 8 or more. The visits seem to go down. So while we left out all the patients with 0 visits, it did raise the count. It still didn't seem conclusive. We thought we'd try restricted the model to 3 or more visits, and that's this next slide. Okay, 3 or more visits. Each of these patients here, we saw therapy visits represented 3 or more times, and I suppose in some ways it's a little bit more dramatic, but again, we didn't feel like it's very conclusive. So one last model, I'll move on to our last model. We thought, let's try restricting it to at least 1 pre-COVID visit and 1 post-COVID visit. So we're restricting to just those people that had some sort of therapy visit in the hospital systems that feed N3C, 1 before their COVID diagnosis and 1 after. Dramatic pause, and here we go. Ta-da! Let's just say the interaction signal goes pretty flat. In summary, like we did with AIM2, let me show you all four models here, all 20 panels here. Here are no restrictions. Here's 1 or more visits, 3 or more visits, and restricting to at least 1 pre-COVID and 1 post-COVID visit. So again, we'd like to open it up. If some of you have ideas about how to attack this research question, we feel like it's a great idea and worth exploring. And we've taken a stab at it, but we'd love to get some more of your input. I see a couple of items in the Q&A. Let's see. racial and ethnic differences in the outcomes of our study. Just overall, yes. AIM 1, that's addressed more in AIM 1. Thank you for your question, Francisco. And we can go back to that slide if you want. Let's see if I can navigate there quickly. Oh, you know what? I apologize. It's not in those slides, but in the last slides in our presentation, we have some ANOVA tables. And let me see. Well, I misspoke. We are not seeing in these ANOVA tables. So I'm afraid I don't have anything in the presentation to really show you any racial and ethnic differences. But you know, that now that I'm talking about it, I do think we looked at that earlier, and it was not conclusive, so we left it out of our model. Lesley, can you correct me on that?
I think you're right. That's we did take a look at it, but it wasn't all the items in this were showed some differences.
Yeah.
So either the representation was underrepresented, but I don't think race and ethnicity came out for the outcomes that we were looking at.
Yeah, that's right. Okay. Next question I see from Cameron. Thank you. Were those individuals diagnosed with post-COVID condition or PSASC? I guess you're talking about AIM 3 right now. Post-COVID condition. We're post-COVID. By that, we're just meaning we're looking at how many visits on average per patient we are seeing in the data after their COVID diagnosis. So we're not talking about a post-COVID condition. I hope I'm understanding your question correctly. Lesley, any perspective on that?
Yeah, I think that I think these questions about PASC are really great. We have not added that to our mix. So in this first group of analyses, we had not made it there. We wanted to kind of establish the issue among this population, but it's definitely one that's warranted. I think there was another question earlier kind of getting at that too. And so there's a whole field of, I agree, there's a whole field of questions that could link to long COVID, to PA, you know, across the board.
Okay, great. All right, and the last question I see anyway, I am going to have to play my understudy card here. As I read this, this is a question about interaction term of group and pre-post for outcome in your GE model. Was it or was it not significant? I am going to have to defer and ask Will to address that question. And I see anonymous attendee. If there is a way, let me invite you to perhaps message Dr. Cottrell later, and I will also copy this question and send it to Dr. Beasley so that he can address it more adequately. Again, I wish I could address this with some confidence, but I will have to defer, unfortunately. Sharon, are you seeing anything else on your end?
I do not see anything else. And Dr. Cottrell, were you okay with me for typing to the answer to put your email?
Oh, sure, absolutely.
Okay, perfect. But yeah, I think that takes care of all the open questions.
Okay, well, great. Maybe a lot of you folks are like me. It takes some time to type your question or formulate the question. Please let me invite you to copy Dr. Cottrell's email address. I feel like I can speak for the entire domain team. I'd love to get your input, start conversations after the fact via email. And yeah, I don't think I need to go over these tables. If anyone has a specific question of some of the figures, some of the some of these ANOVA tables, I can address them, but I'll skip those slides and pass it over back to Dr. Cottrell right here.
Okay.
Thank you.
Thank you, James. It's wonderful. So using that slide that you have up, James, I think the only thing I would ask, and James had initiated this, is we'd really like, knowing that this group was pretty young in terms of other domains. And as you can tell, we're just jumping into a pretty wide array of potential questions. You know, what this slide asks is, we started with OTPT, but there are many others that we were either weren't recorded, weren't documented the way we needed it to be in, or anticipated, I should say, it to be in the medical record. What other outcomes? Again, we started with rationing certain devices, and then that became difficult to follow through within the database. We'd love to hear kind of ideas to see other inpatient treatments or devices or care, ventilators, things of that sort that might be used. Any ideas, because that really challenged us at the tail end when we got to AIM-3 and looking at the database. And then I'm looking at the, yep, so long COVID, those kinds of, maybe that became, with the creation of that, it'll open us up a little bit more. Steroids, fantastic, yep.
Lesley, shall I stop sharing and let you take over sharing so you can see the slides?
Sure, that's fine. Thank you, Jane.
Thank you.
Okay.
Perfect.
Thank you. So steroids, potentially long COVID. I'm looking at, look at the number of visits pre-post COVID according to severity of COVID. Yep, so that interaction, following up on that interaction, absolutely. Keep them coming, that'll great. I'm gonna move forward to the next slide, but please continue to put them in there as you have them. So just as an overview of our first glimpse, let me move some things around so that I can see this. First glimpse at this is, yes, as James mentioned, particularly with the severity and the treatments, we do see some differences, both between the comparison group that does not have a disability, that did not have a disability, and within the disability groups. And I think that's really interesting and something that would continue to motivate us to take a look at this. In some aspects, they had a greater chance of receiving care. So that went against some of the hypotheses that we had. But with the, you know, with limited to the particular outcomes that we could find in the database, perhaps there was some limitations or changes or underrepresented, underserved pieces in other outcomes to be continued on that. Where we had initially thought, or I had initially thought, the IDD group might be the more vulnerable, it actually came out to be those with traumatic brain injuries, which in some other literatures, they are very vulnerable to that because it's not apparent that they have a disability from physical, from presentation, from phenotype, and they are out there and experiencing, or they were out there and engaging where others might have isolated themselves for fear that it would worsen their health even more. So they definitely were a vulnerable group, and we saw that in this. Depending on how we operationalize some of our outcomes, you saw some differences. And so that's something to take account for on the measurement side of things as we move forward. And then the inpatient versus outpatient, whether you count, and we've seen some of the pieces in your comments, even looking ahead to long COVID outcomes, we might see differences from the inpatient to outpatient, whether you count the first, middle, or last. That's definitely going to come into play, and things that we need to talk about and strengthen over time, as well as for the types of therapies. In terms of OTPT, rationing did not happen, did not seem to occur. So it's important to note that piece. All right, we've started to talk a little bit about the challenges faced. The care-seeking behavior we knew could be an issue coming in. to play, and we think it was. The lower rates of reports from individuals with intellectual and developmental disabilities, particularly the developmental disabilities, are something that we need to be mindful of in terms of the database. Again, the patterns differed greatly by time period and how you define it. The severity, again, differences based on how you define it changed in terms of what groups experienced what. And then the OT visits were missing. We chose that one to move forward. That seemed to be the best one, but we still had some pretty significant missing cases even with that. All right, so to try to either both develop or enhance our view within the disability as a second step, but also to try to address some of these measurement issues. Our colleagues are starting to take a look at mental health and how it interplays with disability. So the disability categories, even if we stayed with the 4 categories, how's the mental health representation or mental diagnosis coming into play? And then the functioning within those. So someone who has a more limited functioning, but the same diagnosis, do we see further differences in our findings? We're going to take a look at COVID outcomes, the morbidity, mortality for severe mental illness among the disability categories, looking at that as considering that might be an additive effect, but it may not. And then potential differences, as I mentioned, functioning within those groups. And I see more, again, the long COVID interactive piece within the disability is very, very interesting. And I'm seeing some hypotheses going on that we'd love you to join our domain group and get us going on that. I think that's a great piece. So just to acknowledge, we are very thankful that we had this database to start. This is often, as I mentioned from the beginning, let's go full circle and say that we don't often have databases that even give us an idea or a chance to take a look at disability groups. So this has been fantastic, and there's more to come on that. I'm going to turn it over to Sharon to kind of close us out on that piece, though.
Sure. So thank you. I hope that all the answers have been, or questions have been answered to your liking. And if not, please feel free to reach out to our team. We are very happy to have you on our call, and also some acknowledgements. Sorry, my slides are loading here. But we wanted to acknowledge, like Dr. Cottrell said, that the N3C, the database, the sites that are contributing data, the leadership, NCAT's leadership, N3C leadership, NIGMS for funding us, and that the next team meeting is Friday, May 24th at 1 p.m. Eastern. I have Amber Abel's email in the slides. She is our coordinator for our meetings and helps us out to keep us all together. So hope to see you on the next meeting. And then just the further questions and answers. And I see something in the chat now. Oh, sorry. Okay. So that is, I think, everything. I don't know if there's others to add or any other questions that needed to be answered.
Hi, I'm just going to speak, and I can't find my chat button or my question button, so I'll just ask you. I had a question about the institutionalization covariate. How are you able to get at that? So sometimes we'll see things like they have really long length of stay, and we think that it might be like we're trying to deduce that maybe that's somebody who has long-term care or something, but I'm just wondering how you guys went about that.
So that institutionalization is more on the side of someone in a state institution for someone with a disability, particularly for the IDD. So if they, again, the piece of, for the younger kids, we kind of looked at the welfare piece, the foster care piece, that complexity. But for the disability side, you also have the layers related to, and could possibly get to functioning, but not always. But was the individual coming from an institution to seek care? What care was available to them, and to and fro, rather than within the hospital, length of stay. Although we did look at length of stay.
Oh, are there specific markers or indicators from an institution or yeah, I haven't worked with any of that kind of data myself, so that's really interesting.
So now you're going to get me. I love that whole piece, because it takes us down a whole different road that we kind of stopped and we said, oh yes, we want to get to, but we didn't dive in. So there are, in terms of there's some proxies that you can use, but then with more discussion, I'm sure that we could get at that. But guardianship, even as an adulthood, you kind of look at those factors. And then they note, we did note some pieces where it was recorded that the individual was institutionalized, and across the age groups in particular. So it's something to look at. I'll be too dangerous to dabble in right now, but definitely would love to get into that with you.
Okay, so we should come to the domain team meetings, right?
Please. Yeah. It's a great group. Great group. They're fun.
Yeah, this is fantastic work. And thank you so much for the presentation and answering the questions so thoroughly, and also posting when you guys are meeting. Oh, I think maybe there was one more in the Q&A. Let's see. Oh, how can we access the domain meetings? Do you mind flashing that email up one more time? Or I think it was, please contact Amber Abel for an invite. Let's see.
Yes, sorry, I've got so many tabs open. I apologize, but yes, let me get that contact information up there. And if you do go to the N3C domain team landing page, our team does have a link out there as well. And let me type in the answer here. But we're very happy to see you at the meetings, that's for sure.
Can I chime in and just ask a technical question? I see that you put Dr. Cottrell's email in the webinar chat, and I'm wondering if that went to only the host and panelists and not to everyone.
It did, yes.
Okay.
Unfortunately, I realized that after I put it in there.
Well, I just wanted to make sure Dr. Amber Abel's contact is also going to.
Yes, I just answered it in the in one of the questions, but
Okay, thank you.
Just moved it to so everybody can see it.
oh, thank you. And then I was gonna put, if you don't mind, the link to the oh, I think I just sent it right to you.
Perfect. I can put
Christine,
it to everybody.
to our page. Thank you.
This is the domain team website information.
That's correct.
Great. Thank you all for having us.
Thank you so much for presenting, and looking forward to hearing more work from your group.
Appreciate it.
Okay, guys.
Thank
We'll
you.
see you next month.
Thanks.
Thank you.
Bye-bye.